Do you guys really think I was mad at you?
Yes!
What?
We were so scared. We were
So scared. To imply that I could muster that strong of a feeling towards you all is pretty presumptuous.
What if it was positive emotions?
Love. About that. I'm just kidding. I was not mad. To be fair, though, I've been a little glum as of late. Someone stole the antidepressants out of my office, so whoever did it, I hope you're happy.
Ooh.
Aw, that's very sweet. Okay, everyone get logged in and we'll do our review. Should be out in about 5 or 6 hours and we'll be good. It is what it is. So it is what it is. All right, I'm gonna get you guys logging in still, or do I have some people just want to observe on the sidelines? The code will be there, so I want to get started so we can get moving forward. Oh, actually, hey, so I did want to give you some feedback on the prescription assignments. Overall, I thought they were very good, especially for like your first attempts at doing like medication orders from an inpatient perspective. Couple things I did notice sort of among many of you. So if you did this, don't feel bad. A lot of people did the same things. So for one, when you write the date and the time on there, you only have to write it for the first one and it counts for all of them. You kind of want to think about those orders when you're handwriting them to be encapsulated by one, the date and the time you started them, and then your signature at the end, because you don't want anyone to go in there and write something after you did, and then, or they could squeeze something in there and all of a sudden it looks like you wrote that when you did not. Less of an issue nowadays with a lot of EMRs, but you'll still find places where you have to do paper orders, so that can certainly happen. Other thing, if you just say PRN, so I say, for instance, I say Zofran, 4 milligrams IV push, PRN. How often can that patient get that dose? Every second, every nanosecond, perhaps. It does. You didn't really specify, right? So you want to make sure you put a time frame on there. So for instance, like Zofran is typically Q8 hours PRN, right? So that way, every 8 hours they're able to get a dose, but they don't get it any sooner than that. And if they don't need a dose, then they just can skip it and give it whenever. Okay, so that way you at least put some sort of duration between doses there. If you just want it once, you can write once PRN, and that's totally fine. Okay. Any other questions or thoughts about that? Yes, sir.
For like the antibiotics, if we just give it once, do we have to say giving just once?
Yes, you still want to specify once because you don't want anyone to have to question it, right? You don't want your orders to be ambiguous. So for instance, if it's something like that, I would have to call on that, right? So if you left out an important part of that order, I would have to call you to say, hey, do you actually want this once or do you want more than that? What's going on, right? So that's usually stuff I count off on if I'd have to give you a call, because that's the goal, is to make sure those pharmacists don't bother you and give you calls all day long, right? That's why, especially, a lot of people, actually, and this is a good example here, a lot of people just put 1 dose of Zofran. Now, depending on the indication, what you're probably looking up was in reference to like the immediate post-operative sort of phase, or in the PACU. Typically, though, for those kind of patients, you'd write Q8 hours PRN, so that way they can get other doses. Because what will end up happening is that you may be the on-call person that night. Imagine one of your colleagues wrote that order, just a one-time dose. All of a sudden, you're on call that night, patient gets nauseous, who's the nurse going to call? They're going to call you to get that order placed in, and you don't have to wake up in the middle of the night if you don't have to, right? So those are things, especially like Professor Kaplan, he gets to deal with that when he's on call. All kinds of goofy stuff he gets called on. And it's like, well, if you wrote good orders to begin with, right, stuff that will cover them throughout the night, then you don't have to get those issues there. Yes, ma'am.
So you want us to include the like milligrams per kilogram per hour in parentheses after we do the amount that we are telling the nurse to give?
That is handy to write that, because typically, are you talking about for continuous infusions? Yeah, typically you would do that. You want to write mics per kilo per minute or hour, whatever the dosing units will be for the drug there. The reason why you do that is because that's typically how the nurses will program the pump. They'll actually say, they'll put the patient's weight in the pump and they'll program it in based off of whatever your order is. It's easier to titrate that rather than just giving like a flat dose you're going to administer there. So that's a good thing to consider. The thing with the antibiotic dosing for the post-operative period, typically what we end up doing is a full 24 hours worth. And so depending on the setting, you may or may not do that, but we would end up doing a dose right prior to surgery, and then we do 2 doses 8 hours apart after that, so they get a full 24 hours of ANSEF, which I think everyone did ANSEF, so that's totally fine from that standpoint. Any other questions regarding the assignment? So we have another one due Friday night, right? I believe, and then we'll have our test on Monday there. So very good. Okay, only 43 people want to join in. It's like a third of you that don't want to participate. It's very sad. Oh well.
We're trying to learn.
I guess so. Okay, so let's see. Which of the following areas can you safely inject lidocaine? I don't think I covered this directly in the actual lecture itself. But this is a good point. Maybe you cover this in surgery. You want me to raise this up somewhere? What areas can you safely inject lidocaine? What do you think? Oh my goodness, so much talking. Actually, you can give lidocaine any of these areas. However, did you learn any caveats in surgery? If you add epi, these are areas you cannot inject. And why is that? Because you cause vasoconstriction. These are terminal areas of blood flow, so basically the in and out is very, kind of right there at the very end. If you cause constriction there, potentially you can lead to decreased oxygen delivery. You get tissue necrosis that can happen there. So these are areas where you typically would not want to administer epinephrine. Lidocaine itself, though, would be totally fine, so no issues with that there. That makes sense. I just want to make sure you guys are aware of that point. Up next. Which of the following is most likely to affect QTc interval at therapeutic doses? Which one of these agents? Quetiapine, sertraline, clonazepam, or buspirone? What do we think? Notice it said most likely, not just which can. Oh, interesting, interesting. So remember, for the most part, at least for my purposes, for my testing, QT prolongation is not a major issue for the majority of SSRIs. Can it occur? Maybe, but it's unlikely to happen. Which two, though, is there an exception to that? Escitalopram and citalopram. Those two can definitely do it. However, certainly when you're looking at the atypical antipsychotics in particular, those definitely do prolong QT. So that one, it would be most likely out of this group to do so. Okay, so keep that in mind. Atypical antipsychotics commonly can cause QT prolongation. Okay, and then clonazepam and buspar, neither one of those would be really an issue from that standpoint either. All right. A patient with ADHD and substance abuse issues would benefit most from which of the following agents? Be mixed amphetamine salts, bupropion, dexmethylphenidate, or atomoxetine. What do we think? Yes, very good. Atomoxetine. So, when you're thinking about management for ADHD, remember that, or at least in this case with substance abuse issues, why would Adderall not be a good choice? It's a controlled substance. It's an amphetamine. It can certainly cause addiction, so that would be a risk in those patients there. You may want to avoid that. Dexmethylphenidate similarly could also do that, but no one picked that answer. Bupropion is typically used for what? As an antidepressant, maybe smoking cessation, maybe for weight loss potentially, and mixture with naltrexone potentially. But really, atomoxetine is the only one on the list here that is a non-narcotic, non-stimulant agent here that is used for ADHD specifically. Okay, so it works as an SNRI, but we don't use it for depression. We use it specifically for ADHD. Which one of these would have the fastest effects for treating ADHD symptoms? Adderall or the dexmethylphenidate will do it too, right? Because again, they're both having the same mechanism. They'll both kick in pretty quickly there. Atomoxetine would take a few weeks, just like we would think with like depression. Okay. Which of the following drugs can be used as a mucolytic in the CF patient? Use Dornase alpha, azithromycin, Tobramycin, or 3% saline nebulization. Is that 3% is a hypertonic or hypotonic? or isotonic? Hyper, right? What's isotonic? Saline, 0.9. Very good, very good. How many milliequivalents per liter of sodium are in 0.9%? 154. It's a very good number to know, because if you have like half normal saline, then you know it's how many 77 milliequivalents per liter. Very good. Yes, so Doronase alpha and actually that 3% saline nebulization can do the same thing, right? Using a hypertonic solution like that helps to draw more water into the mucus and makes it less viscous and better able for the patient to eliminate that. Doronase alpha, how did that one work? It's a DNase, right? So it's an enzyme that actually cleaves the DNA within the mucus and helps to kind of break it down a little bit from that standpoint. What would I use azithromycin for in these patients? Yes, more than anti-inflammatory. So it'll typically be on like a Monday, Wednesday, Friday schedule. You typically won't see this used for strictly just for an infectious case there. And then the Tobramycin would be used when? No. So this one would be for treatment of infection, and this is where you would find patients that are chronically colonized with Pseudomonas. That's where the Toby nebs are going to come into play there. So that one is definitely handy. You'll typically see them like on it for 28 days and then off for 28 days, and they kind of cycle on and off of that, and it helps out with the colonization and kind of keep that under control to some degree. Is resistance still an issue if you're using like an inhaled antibiotic? Less so, right? Because concentrations are going to be much higher using an inhaled form right there in the lungs versus if I use like a systemic drug. Very good. Which of the following can be used to treat both hyper and hypothyroidism? Use iodine, propylthiouracil, methimazole, or levothyroxine. Pull double duty. Yes, very good. So iodine is really important because you need that in order to actually form the T3 and the T4 in the first place, but really high levels, if you recall, can actually help to suppress that. So you can either maybe use high concentrations of potassium iodide prior to, say, like surgery to help shrink down the thyroid gland. You can also use it as a supplement in a lot of cases. Which ones are going to be used for hyperthyroidism? Yeah, methimazole and PT are going to be used there, right? They help to block the production of T3, T4, and then levothyroxine is just what? That's just T4, right? So that's obviously if we're going to be for the hypothyroidism there, just as a replacement, right? What's the kind of onset of action for something like levothyroxine? About a week or so before you really start to see some of that conversion over to T3. Yep, very good. I'm glad that like you guys just thinking I was mad at you had such a profound effect on you. Really shows you care. So gives me the warm fuzzies a little bit to know that I can instill that kind of fear into you. Which of the following could cause lithium levels to rise in a bipolar patient? Would it be dehydration, polydipsia, eating a whole bag of salty potato chips, or starting treatment with amlodipine? What do we think? Cause elevated lithium levels. You know, I went to the store the other day to pick up an 8-pack of Sprite, but I only picked 7 up. All right. So why would, for instance, polydipsia not cause lithium levels to rise? Now, if anything, it would cause a dilutional effect sort of in the acute phase, but then also cause you to urinate more, which could help to get rid of some of that. How about the bag of salty potato chips? Well, that would put you in a state where your kidneys say there's too much sodium, and so it's going to try to get rid of that, right? So you will then get rid of sodium, and then lithium goes along with it, right? So they tend to go in the cases there. And in fact, if I had someone who had, say, for instance, they were to come in, maybe they're having tremor, they're having some ataxia, slurred speech, things like that, and then I checked the lithium levels, they came back high, say it was like 2.5 or something milliequivalents per liter. You know what the first thing we give to those patients is? A salty bag of potato. No, I'm kidding. We actually use normal saline. We actually will give them very high rates of normal saline, and that will put the body and the kidneys into a state where it wants to get rid of that extra sodium, and then it will get rid of that lithium along with it. That's the first thing we'll do for those patients. But dehydration certainly will cause you to retain more sodium, to help to retain more water, and thus more lithium will stay along with that. Are there any antihypertensives that could cause lithium levels to rise? So diuretics for sure can do it. Your ACE inhibitors and ARBs will do it as well, right? Any other classes of drugs that will cause lithium levels to rise? NSAIDs tend to be another big one, right? Because a lot of times patients will take NSAIDs over the counter without you really knowing about it, and that can lead to issues as well, okay? So again, just keep in mind, if you're in a state where the kidneys are holding on to sodium, you're going to hold on to lithium. If it's trying to get rid of sodium, it's going to get rid of lithium as well. All right. Which of the following insulins would be best to correct postprandial hyperglycemia? We have insulin Lispro, Glargine, NPH insulin, or insulin Degludec. You just covered all this with Professor Kaplan, right? So you guys know all the different insulin types and 3 times over, you said? Well, good. That's okay. That's okay. Repetition is the key to adult learning, as it turns out. Very good. Okay, so when would I use insulin Glargine?
At night.
Long acting, you could use it at night or you could use it in the morning time, usually once daily for the most part. Insulin Degludec also fits in that ultra long acting category there. NPH you would give when? Maybe like twice daily in some cases, about 12 hours in terms of duration. So you may give it like, say, at morning and with breakfast, and you may give it with lunchtime potentially or later on. So about 12-hour coverage there. The insulin Lispro, though, Humalog, very fast acting. What else could I give for postprandial hyperglycemia? Aspart would be another good one. No. Glucagon would be another good one. And then regular insulin could be used too, right? So you could use just normal Humulin, Novolin, any of those are totally fine. Very good. In pediatric patients, which of the following means a drug dosing is least sensitive to extremes of weight? So if I was doing weight-based dosing, height-based dosing, age-based, or body surface area, which one would be sort of least sensitive to extremes of weight? Could have asked that question more clearly, perhaps. I don't know.
It's like a Kaplan test.
What?
It's like a Kaplan test. I can just understand the question.
Yes, okay. So why would age-based dosing be particularly sensitive to extremes in weight?
Because they're not paying attention to the weight.
It has nothing to do with the weight, right? So you can, like I mentioned, I had an 18-year-old patient that they wanted an adult dose of an enema on. The person weighed like 15 kilos or something, right? So again, patients with extremes of weight, and you'll find this especially with kids with a lot of like chronic illnesses, or if they have, you know, especially like a lot of these genetic abnormalities, where they have like chromosomal deletions and additions and all kinds of stuff. They typically will be on those kind of extremes there. The best way to do it, though, the one that would be least likely to be affected by that is body surface area, because not only does it take into account the weight, but also what else? The height of the patient. So that's what we do frequently for like chemotherapy. We do it all the time for chemo drugs because we want those to be very exact based on the individual patient. Now is a good time to mention that I did put 2 drug dosing calculations on the test for pediatrics. One's going to be a fluid one. So how do you figure out a fluid bolus for a peds patient? What's the dose?
30 times the weight in kilograms.
So for fluid bolus, 20 mLs per kilogram, right? And then the 4-2-1 rule. Do I need to go over that again for you guys? Everyone knows that, right? You've done this before, no big issue, right? The other one's going to be based off of like an oral suspension, like a prescription you'd be writing there to figure out the volume to administer it. It will be math that you can do with your scratch paper and in your head. No calculator will be needed. But make sure you read the question carefully to make sure that you understand what I'm actually asking for, okay? So just beware, there'll be, I can guarantee you on the test, there'll be one question about fluids and one about the drug dosing, and that's it, okay? Everyone with me? Perfect. Fantastic. I won't even tell you the drug, but I will tell you that there's 2 questions. That should have been the free answer for whoever won at the very end, but it's going to be extra nice. I hope Angry Wood wins. That'll be... Would smash. No. Which of the following would be most likely to cause weight gain? Would be liraglutide, metformin, glipizide, or glucagon? What would you expect? What would be most likely to cause weight gain? Interesting, interesting. Yes, so glipizide definitely would be most likely. And why is that? Causes insulin release. That insulin's going to shuttle those carbohydrates into the cells, and that can lead to storage later on as fatty acids and adipose tissue deposits, right? So definitely that one's going to cause weight gain. Which one of these would be most likely to cause you to lose weight? Metformin, or is there something else maybe? Remember the GLP-1 agonists, the incretin mimetics, like liraglutide would be the most likely, right? There's that story of my uncle I told you where you end up dropping a ton of weight. That's going to be those GLP-1 agonists, right? So metformin typically is going to be what? Neutral to maybe a little bit of loss, right? So I wouldn't say, if the question was which one's most likely, not which ones can. If I said weight loss, then liraglutide would be the correct answer there. Glucagon, remember when you're going to be giving glucagon? If they're hypoglycemic, so again, and if anything, glucagon does what to insulin secretion? Suppresses it, right? So I wouldn't necessarily expect to see any issue with that one. However, it could actually cause you to lose weight because glucagon frequently also causes what side effect?
Appetite loss.
Yeah, because they're really nauseous, right? Cause a lot of nausea and vomiting, so you end up seeing that quite frequently for those. Remember, it also like loosens that lower esophageal sphincter. We use that sometimes to help pass foreign bodies. But yeah, glucagon is very notorious for causing a lot of nausea and vomiting. We actually use it quite frequently for like beta blocker or calcium channel blocker ingestions. You can actually use this to help get heart rate and blood pressure up via mechanisms I'm not going to bore you with now. But we certainly will use like glucagon drips, and they frequently get very nauseous. We'll have to pre-treat them with some Zofran there. Up next, a patient with an allergy to lidocaine could safely receive procaine, prilocaine, bupivacaine, or mepivacaine. If they have a true blue lidocaine allergy, which one could they get? We have two big differentiations in our anesthetic agents. Very good, right? So remember, what are the two classes sort of chemical structures? There's amides and there's esters. How do you identify an amide? There's an I before the cane. So lidocaine has an I, so that's an amide. Which three are also amides up here? All the wrong answers, right? Because those would cross-react potentially because they share that amide structure. So prilocaine, mepivacaine, ropivacaine probably wouldn't want to give there. Procaine, that would be reasonable because that doesn't have the I, so you know it's an ester local anesthetic. People typically are more likely to have allergies to esters than the amide, so this may clinically not come up specifically, but you should be able to know the difference between the two and which ones would be safe to administer, okay? All right. A diabetic patient develops a fungal UTI. Which medication most likely caused this? It would be canagliflozin, insulin detamir, sitagliptin, or duraglutide. Again, whoever names these diabetic drugs, really tongue twisterish kind of names, not fun. Very good. Why would this one cause a fungal UTI? Causes you to pee out all that sugar, right? Because remember, it blocks that SGLT2 transporter in the proximal convoluted tubule. It prevents reuptake of that glucose, so you end up just urinating it out. Remember what it likes to eat glucose besides us?
Everything.
Everything else. So the fungi will grow. Even like there's been cases like Fournier's gangrene has caused because of this. So be really wary of that. So especially if they have like a history of like recurrent UTIs, maybe they have some anatomical issues where making them more prone to UTIs, this may not be a great set of drugs for them, right? Which ones of these would also likely cause weight loss? Certainly duraglutide would, right? Because that's an incretin mimetic, which else would cause weight loss? So the Januvia, the sitagliptin, although it does help to prevent the breakdown of GLP-1, right? It's a DPP-4 inhibitor. You're not going to see as drastic changes in weight as you would with an actual GLP-1 agonist, right? Because then you're just kind of replacing what the patient's not making versus blocking the breakdown of what little they have. So maybe not a whole lot of changes there, but definitely with those SGLT2 inhibitors, you'll certainly lose weight. And why is that? You're peeing out all that extra sugar, and you're not going to be able to transport that to the cells, right? You can't hold on to it because you're just getting rid of it. So you'd occasionally see weight loss with that one as well. Okay. All right. What is a drug of choice for acute dystonia after taking haloperidol? Someone comes in, they're locked in, their face is grimacing, maybe their tongue's protruding. What would I give? Fluphenazine, olanzapine, trihexyphenidyl, or metoclopramide? Very good. Trihexyphenidyl would be correct because trihexyphenidyl does what? It's anticholinergic. Remember when you're blocking all that dopamine due to haloperidol, because that's a high or low potency agent? D2 block. High potency D2 blocker. That and fluphenazine actually would be the two biggest ones there. And in fact, fluphenazine would just make it worse, right? Giving metoclopramide, that make it better or worse or no change? Reglan would make it worse because it blocks D2 receptors, right? How about olanzapine? That would likely make it worse too, right? Because it still will have some degree of D2 receptor blockade. Now, however, if I had a patient who I knew had a bad reaction to haloperidol, maybe what I could give instead to that patient would be something like olanzapine, because much less potency there at the D2 receptor. But if I needed to actually treat the acute dystonia, I could do trihexyphenidyl. What would be some other alternatives? Benadryl, use diphenhydramine, what else? Benztropine, yeah. So I would see for acute dystonias most commonly, I end up seeing Benadryl, like in the ER setting. I would use that most commonly. Also easy to get over the counter for patients that need to continue taking it. I see for more like kind of chronic management, I'll see more Cogentin or Artane being used for those patients there. Right. Very good. Which medication can be administered via endotracheal tube to premature newborns with respiratory distress syndrome? I give caffeine, lumacaftor, ivacaftor, dexamethasone, or Baractant. Very good. Easy way to remember this. These little premature neonates are being born. What are they missing a lot of? Surfactant. So I'm going to give them something to replace that. And so if you see an actant at the end of the name, you know it's a surfactant replacement, right? Again, that would be actually instilled directly down the endotracheal tube. That way you can reposition the baby too and make sure you get to all lobes of the lung, ideally. When would I use caffeine? Not necessarily like sleep apnea, but just like apnea in general of a newborn, right? Maybe they don't have enough respiratory drive coming from the brainstem. So caffeine's going to have to stimulate that quite a bit. There's other things you can do first, like physical stimulation. If you're like kind of touching the bottom of the feet, can kind of help out with that. But caffeine is a big one we'll use quite frequently. That one, IV, PO, either way is totally fine. When would I use Orkambi for our patients? That's for CF patients, right? Remember, it helps to cause you to make more and transport more CFTR transporters up into the actual cell membrane there. Good. Dexamethasone, it's a corticosteroid. Lots of indications for that use for sure. All right. Yes, angry wood in front. I'm just kidding, I don't play favoritism. A patient taking Zolpidem for sleep is at risk for all of the following except, so it's an except question, seizures, tolerance, physical dependence, or daytime drowsiness. Which one would they not be at risk for? Anyone look up the Ambien walrus? By chance? Isn't that kind of wild? Yes. Very strange. Yes, okay, so seizures would not be a risk, and why would that not be a risk with these patients? What does Zolpidem activate? It helps actually activate some of those benzodiazepine receptors on the GABA A channels, right? That's how it makes you sleepy. It does work on the same spot that the benzodiazepines are essentially, right? So seizure would definitely not be a risk because it would be actually able to treat a seizure, not that you would use that particular drug. Can you get tolerance to these medications?
Yes.
Yes, absolutely. Can you get physical dependence?
Yes.
Yes, you get a lot of rebound insomnia that happens if patients don't titrate off of these or they're using them pretty chronically. Those are issues. And then obviously daytime drowsiness is going to be a big side effect for a lot of these, especially the longer acting ones. If you include any other CNS depressants like alcohol, anything like that will certainly make a daytime drowsiness a lot worse. Okay. Is zolpidem a controlled substance?
Yes.
Yes, right. Any of those benzo-like drugs will certainly be a controlled substance. A diabetic patient suddenly passes out. An AccuCheck shows a blood glucose of 35. How do you proceed? Guys familiar with an AccuCheck? It's a little finger stick, bedside, point of care sort of blood glucose you can check. It's kind of like how we say like Band-Aids to refer to adhesive bandages or Kleenex to tissues. An AccuCheck is like that for point of care blood glucose testing. So do I give 15 grams of simple carbohydrates, 1 milligram of glucagon, 1 gram of metformin, or 4 units of regular insulin? Oh, who picked the insulin? You don't like the patient very much. So we're going to get that rest of that glucose taken care of for you, buddy. Don't worry. Very good. So why would the 15 grams of simple carbs not be great? The patient is passed out. If you try to give them a cup of milk, they're probably going to aspirate that, and you're going to cause way more problems than you started out with. How about for the metformin? Not really going to help out at this point. It's an oral agent anyway, but again, not great. Obviously, the 4 units of insulin would just drop the glucose even further. Not a great idea in this case here. But the glucagon, giving it IM is certainly going to be indicated. A lot of these patients will have a prescription for that and will have it available along with all their normal supplies. So they recommend they carry that around, but they may or may not, right, depending on the situation. If that was not available or if I needed to give something else, what could I use?
Dextrose.
Yeah, you need the IV place, get the dextrose going at that point, right? All right. Which of the following conditions would be improved by starting a patient on transdermal testosterone? Be benign prostatic hyperplasia, osteoporosis, gynecomastia, or congestive heart failure. Yes, osteoporosis would be correct there. So let's talk about each of these cases. So why would BPH not be improved with testosterone? Remember, so testosterone gets converted to DHT, and that has hyperplastic sort of effects on the prostate there, right? So that's frequently a reason why you end up developing BPH in the first place is due to that increased growth of the prostate due to the presence of testosterone. So guess what we give to prevent that? We talked about the 5-alpha reductase inhibitors, like finasteride. We could do those to prevent that conversion over, and that helps to actually shrink down the prostate. We'll get more into that when we get into the urology section later on. How about CHF? Remember these steroids, they can actually have some mineralocorticoid effects. They'll actually cause some fluid retention, may worsen edema for those patients. That would not be great. How about the gynecomastia? There you go, right? So remember, testosterone gets converted to estrogen via which enzyme? Aromatase, right? So it could actually make that worse in some instances. However, that can be positive though for the bones, right? So you can actually see some positive effect. Both testosterone itself has positive effects on the bone. Also, any of it gets converted to estradiol is also going to be good for that additionally. Okay?
It's like a babushka doll, that one. It's just like a babushka doll.
Oh yeah?
That was,
Isn't it Matryoshka doll?
I thought it was, I don't know, it might have multiple names.
I think babushka is what you call like the Russian grandmas.
The Russian candies.
Hmm?
The candies. Babushkas.
Yeah.
I don't know, anyway.
That's what I was saying.
Yeah.
So what's funny though is my daughter, she watches this show called Masha and the Bear, and you can tell it was like a Russian animated show that they like voiced over with English stuff, and they love it. I have no idea why, but it's weird to see like these little like Russian things that pop through, and I'm just like, why didn't they convert that over? Like they did like translate some of the writing and stuff. I'm like, can I just not read right? Or do I have a stroke? No, it's just in Russian still. Anyway, let's see. Which of the following is most appropriate for a 4-year-old male to prevent constipation? What could be used kind of chronically to help prevent constipation in a 4-year-old? Sodium phosphate enemas, polyethylene glycol, glycerin suppositories, or magnesium hydroxide? Very good. Yes. So remember, depending on how we're using, and the dose matters here, right? So I can give large doses of polyethylene glycol in cases like Miralax or something, or not Miralax, Go Lightly, and basically use it to flush out things quite frequently or quite quickly. You know, we'll have. I usually, at least when I'm working on Mondays at Nemours, I'll at least get 2 or 3 kids that are being admitted just for GI cleanouts, and they're always having to get NG tubes placed or run that Miralax through because it's really hard to drink. Anyone remember what it tastes like? Like warm sweat, because again, it's like room temperature and it's all those electrolytes and everything. So, but using smaller doses, you can use that chronically, right? What else could I use, say, chronically every day to help with prevention of constipation? Like fiber, like Metamucil, psyllium husk, all that's going to be totally fine in those cases there, like non-digestible fibers. Sodium phosphate, obviously that's going to be, as an enema, going to be used more for like an as needed acute sort of issue, for acute clean out. How about mag hydroxide? It's going to cause a lot of diarrhea. Typically, we would not recommend that for kind of chronic utilization. And then glycerin suppositories will work kind of similar to the enemas. They're probably for a 4-year-old, that's going to be not quite enough to actually get things moving. We'd probably end up using a fleet enema for those kids there. And again, frequently we'll get orders for these bowel cleanouts. I mean, if they're bad enough to get admitted, frequently they're on Go Lightly. They're going to get mineral oil enema. They'll get usually Senna on there as well. Senna does what? It's a stimulant laxative, right? So again, add all this stuff on there because again, they want those kids to get clean out. These kids are extremely constipated. Yes?
At what point, like what age, would you stop worrying about hyperphosphatemia?
I would say once they're past, like certainly past 2. I get orders sometimes for the fleets enemas, you know, at around like, you know, a year and a half. I get a little bit more cautious about that. I'm more considerate of the dose they're administering. So there's, and not that I'll test this specifically, but there's like an adult fleets enema and then there's like a pediatric fleets enema. And so frequently they'll say, well, it says pediatrics, I can give it to any pediatrics patient. And that's not really true. They'll try to give that full pediatric one to like a 2-year-old, and it may not be appropriate based on their weight. So typically I'll try to make sure I intervene and get them to only give a half of one, right? So nurse will basically pour out half and they'll administer the rest of it. So yeah, but yeah, it's certainly going to be that concern there. About a 4-year-old, I probably wouldn't be too, unless they were using multiple doses. Remember, you get these over the counter, so mom may have given one at home and then they get another one in the ER. May be some issues there. Okay. Which of the following is true of renal function in neonates? I'm going to say that prematurity increases the function and quantity of the nephrons. Urine output is the least accurate way of measuring function. Serum creatinine is falsely elevated for the first several days, or the Cockcroft galt is the preferred formula for calculating function. Very good, right. So obviously prematurity is not going to increase the number and the function of the nephrons. That makes good sense there. Urine output, though, typically is the most accurate way, right? You can directly tell how much fluid they're actually passing through. So that's actually a good one. What's a good urine output for a kid? Yeah, especially like for a neonate, anything greater than 1 ml per kilogram per hour. If it's 1 ml an hour, that'd be pretty low, right? So 1 ml per kilo per hour is what you're kind of looking for there. Anything above that. And again, remember when they're first born, especially that first couple of days, they typically lose weight because they're usually diuresing a lot of the fluid that they actually had picked up from the mom. So that's something to watch out for there. You're starting to see their weight drop, and then as they're eating and stuff, they'll put it back on. What about Cockcroft galt? Why wouldn't we use that for pediatric patients? Remember, anytime you're using a calculator, you have to consider who is it validated with. And Cockcroft galt was for adult patients. So again, these are not little adults you're dealing with; these are children, and so this is not going to be useful for that. There's what we have what we call a Schwartz equation that we'll use for pediatrics because it was specifically designed and validated based off of that, right? Because they did a study, looked at a bunch of kids, and they found a model to be able to fit what they were finding there, and they were able to get that equation essentially, right? You guys remember models and equations and all of those we were talking about back in Epi Bio? I'm actually taking a faculty development course about integrating evidence-based practice into your teaching. And the first whole week of it was just like biostat stuff. And I was like, oh my gosh. I was watching the video and I was like, it's that boring. I can't believe I subjected them to that. I'm just kidding. It was riveting. I loved every second of it. Anyway, so back to the question, the serum creatinine is falsely elevated the first few days. Why is that? You're measuring them, right? Because again, serum creatinine will hit an equilibrium, it'll hit a steady state just like any drug will. And so for that first couple of days or so, they're still reading the mom's serum creatinine. It will then drop down as they will be able to clear that out through the kidneys. So we frequently, in the neonatal period, won't use their serum creatinine as any kind of measure. Once they get a little bit older, though, and we're sure that that's what they're producing, then it will go up. And plus as well, where does the serum creatinine come from? Comes from the muscle, right? It comes from byproducts of muscle breakdown. And so that's why you end up seeing that neonates frequently don't have a ton of muscle mass either. So that's another reason why that may not be a great indicator of true renal function for those patients. Okay. Which of the following would treat an acute anxiety attack most quickly? It would be desvenlafaxine, buspirone, alprazolam, or fluoxetine. Very good. Right. So why would that one work the fastest? Because it's a benzo. It's directly activating those benzodiazepine receptors, opening up the GABA channel. Things flow in. Works very quickly, right? In order, just like for seizure management, what's the first thing you give them? Give them a benzo, right? So it makes sense that this would be also very quick acting. All these other ones, while they may be able to be used for anxiety, they're not going to be used for acute attacks, right? So these are going to be things that are going to be more slow acting for the most part. Even buspirone is going to be taking longer to kick in than something like a benzo will for sure, okay? Which ones of these are controlled substances? Alprazolam, any other ones? They're not, right? None of the antidepressants are going to be a controlled substance. Buspirone is a good alternative if you need a non-controlled substance, right? What is the maintenance fluid rate of NS for a 23 kilogram patient? Give you a little bit of practice for this one. Very good, right? 4-2-1 rule. What would 460 be? That would be their fluid bolus, right? So you'd order 460 as a bolus, potentially. If they're dehydrated, and then you could start them up on the maintenance rate. Again, you get how many mLs per kilo for the first 10? 4, to a total of 40 mLs an hour, right? For the first 10 kilograms. And then for the second 10, 2 mLs per kilo per hour, so a maximum of 20. A total of 60 so far. And then you add 1 ml per kilo for each subsequent kilogram, so 3 more, so 63 in total, right? I would recommend you be able to do that for a test. I don't know about tomorrow, but at least on Monday. Which of the following would be the best initial treatment for type 2 diabetes? I give acarbose, rosiglitazone, regular insulin, or metformin.
None.
None? You don't think so? What would you do instead? Oh, diet and exercise. Okay. Well, the next time they come back, what do you do? You're absolutely right. Should be diet and exercise first. Absolutely. That's true. Very good. Yes, everyone should be starting on metformin unless renal patients, they have significant hepatic dysfunction. I probably would be cautious there as well because we may not be able to process that lactic acid. But yes, definitely renal dysfunction, like creatinine clearances less than like 30, would not want to start this in those patients there, right? Which one of these would synergize well with metformin? Insulin would. What else? Acarbose might, right? What else? Any of them would, right? So metformin is a really good backbone. If you go back to that chart, you remember metformin was always the backbone. You can add really anything to it, and that would be totally reasonable there. What kind of patients would be bad candidates for something like acarbose? That's actually good for pregnancy, right? Because remember, that's when the alpha glucosidase inhibitor that doesn't get absorbed, right? It just blocks. It does cause gas, right? Because all that extra sugar in the GI tract, it's metabolized by bacteria. So who'd that be bad for? inflammatory bowel disease, right? And actually, one thing you'll see there potentially is like, not necessarily for type 2s, you see very rarely would you ever see something like that used for a type 1 diabetic patient. But remember, type 1 diabetics frequently is due to an autoimmune condition. Sometimes they'll have autoimmune conditions can kind of come in multiples, so it's not uncommon you would have, say, a patient with type 1 diabetes that also develops something like Crohn's disease. And so again, that would be definitely a contraindication using something like acarbose, right? Okay, and then trying to think of any other points there. Which one of these would be most likely, or would be bad to use in a patient with, like, say, a previous history of MI? Yeah, rosiglitazone would not be great for that one. Pioglitazone has not been shown to have that same sort of interaction there. Okay. When would you start a type 2 diabetic patient on insulin? Yeah, so probably once I've tried out metformin plus a plethora of other agents and they just can't get their stuff under control, then I consider adding it on, right? Definitely I would want to try something like a GLP-1 agonist beforehand if possible, right? So that way maybe they'll get like a once weekly injection, but depending on coverage in terms of insurance, it may not be possible, right? All right. Which of the following should be avoided in patients taking Phenelzine or Nardil? Fava beans, tilapia, roasted turkey, or white wine? Very good. Yes, fava beans was on the list. You don't want to administer those. Why would I not want to do that? Yes, it contains high amounts of tyramine, right? So definitely, you know, fishes, a lot of poultry, not going to be a really big issue in terms of tyramine. What might contain a lot, though? Like smoked meats, aged meats, things like that, aged cheeses. What kind of alcohol? Yeah, typically red wines typically contain more tyramine, right? So those are the things you want to be watchful for. Again, I don't know how many times I've seen anyone ever eat fava beans. I don't know if I've ever eaten a fava bean before, but it's something you want to know about. Anyone know what other condition patients should not consume fava beans? G6pd deficiency, and actually another name for that is what? Favaism is actually another name you'll find. Yeah, so they can actually cause a oxidation reaction that they can't really process because they lack that enzyme, and that can actually induce things like hemolysis, methemoglobinemia. It's pretty interesting sort of disease state. It's important for medications because many medications can actually exacerbate that as well. So big ones like dapsone, for instance, if you ever see that. But moving forward, patients being started on paroxetine for a major depressive disorder should avoid which herbal supplement? St. John's wort, melatonin, valerian, or ginkgo biloba? Yep, St. John's wort. Why would I not want to do that? Risk for serotonin toxicity, serotonin syndrome for sure, because again, they're both doing the same thing, right? What does St. John's wort do essentially? Blocks that monoamine oxidase. So not only do you have the SSRIs that are blocking reuptake, but you have something blocking the metabolism thereof, so you have serotonin syndrome being a risk there. And these other ones would be totally fine. Some patients, you know, they may experience insomnia, so they may require something like, you know, some melatonin or valerian root to help out with that. Just depends on the patient there. All right. Which of the following meds carries the biggest risk for rash and Stevens-Johnson syndrome? Let's say we have a bipolar patient. Keppra, lamotrigine, trazodone, or fluoxetine? And like, we didn't even talk about Keppra this section. I'll be like, yep, because I forgot to take that one off of there. But regardless, which one would carry the largest risk? It's still Lamictal, yes. Remember, it's one biggest risk for causing rash. Stevens-Johnson's the biggest risk. What would I be cautious of warning patients about with trazodone? Or should I tell them to be worried about? Priapism is something that can happen, right? What else? Hypotension is a big one too with trazodone. Remember, it blocks those alpha-1 receptors, so you can see some hypotension. Very sedating as well, so that's why you may see this being used more for sleep more than anything else in a lot of cases. Okay. All right. Close to the end. Which sedative agent can be used for induction prior to surgery? I guess sevoflurane, cisatracurium, desflurane, or propofol. I don't think we talked about cisatracurium yet, so I'll go tell you that's not the right answer. It's actually going to be a paralytic agent that we'll talk more about in the ER section, I think, later on. Yes, propofol is a really good one. Why is that a good one to induce anesthesia for patients? That's the rapid-acting IV agent, right? Remember, it takes time for the inhaled ones to really sort of kick in. So things like sevoflurane, desflurane are better for maintenance of sedation. They may still use it in conjunction with things like propofol. That's generally how you'll see that being used. They'll knock them down with something, maybe a thiopental, maybe a ketamine, whatever, propofol, and then they'll maintain that with an inhaled anesthetic there, okay? What is a risk, what kind of big side effects would you worry about with propofol? Hypotension is a good one. What else? So you mentioned acidosis, right? You can certainly see acidosis. This is actually a concern we had for a patient. We had a child who was on ECMO. You guys know what ECMO is? It stands for extracorporeal membrane oxygenation, where basically it's a machine where we'll cannulate the patient, we'll take the blood out of them, we'll take off all the bad stuff and put all the good stuff back in, namely things like oxygen, right? Where basically we're breathing and doing the function of the heart and the lungs for the patient there, okay? Anyway, but point being is that there's a lot of drug considerations for that, one of which being that propofol actually binds up to the tubing pretty significantly. So it's one of those things where we had this kid that was getting this really, really high dose. And so one of the concerns that we had for administering this much propofol to maintain that sedation for them was the fact that you can develop that, what they call PRIS, or that propofol-related infusion syndrome. And actually, it's more of a metabolic acidosis they develop there rather than necessarily being more of a respiratory one. But so acidosis, I would certainly be concerned with large doses for long times potentially. You guys laughing about? Nothing. Anything else you'd see with propofol? Any unique things? The green urine, absolutely. Very good.
There's the green answer.
That's the green answer, right? So I didn't even plan that. It worked out perfectly. How about anything you'd be cautious with or looking out for with like sevo or desflurane? Malignant hyperthermia. Very good. How would you know if they have malignant hyperthermia? So the first thing you would notice is their temp, right? Their temp would get very, very hot. They get hyperthermic. You'd actually end up seeing CO2 output actually would go up pretty significantly because their muscles are so tightened up that they're starting to produce a lot of byproducts thereof, right, of that aerobic metabolism. So a ton of CO2 is going to start coming out. You get very hyperthermic. Someone, I think, said pee brown. Why are they peeing brown? Eventually will develop rhabdo, right, and all that myoglobin coming out of the kidneys looks brown like that. How would I treat that? Dantrolene is going to be a peripheral muscle relaxant. Very good. What else can I do? I would probably stop giving them the gas, absolutely. What else? Cool the patient down, right? So either cooled IV fluids, you can use evaporative cooling techniques, whatever you need to do. And then bicarbs is going to be another big one because those patients, as they use up all their ATP and they switch over to more using anaerobic metabolism pathways, you're going to find that they will then become very acidotic. So bicarb is quite helpful for that as well, okay? All right. Which opioid may cause chest wall rigidity when given too quickly? Hydromorphone, heroin, morphine, or fentanyl? It's a particular risk with surgical patients, maybe getting big doses. Yes, fentanyl would be that one there, right? So that's a unique side effect for fentanyl that will cause a chest wall rigidity, which would make it difficult to oxygenate the patient because that chest wall is not really being very compliant there. And so that can be difficult when you're intubating the patient and they're kind of tightened up like that. Typically, you either have to give like a paralytic to reverse it or maybe even naloxone to help reverse those effects there. So typically, giving it slower can help out with that. You have a question?
Oh,
No? Okay. All right, last question. Which of the following would have the fastest onset to treat hypothyroidism? Would it be Liatrix, levothyroxine, liothyronine, or saturated solution of potassium iodide? Interesting. So SSKI would not be very fast. Why?
because it works at the bottom level. You have to take up the iodine to make the.
Exactly right. So this is going to be probably the slowest out of anything because it's going to be the precursor to actually make the T3 and the T4 eventually, right? Levothyroxine can be fairly slow because it's T4. You got to convert it over, right? How about the Liatrix? Why is that not one? Remember, it's that natural balance, that natural ratio between the T3 to T4. So there's a little bit of T3, but it's not going to be like liothyronine, which is all T3. So that one had the fastest onset of action for those patients there, right? Make sense? Okay. Let me see who the winner is.
Oh, there's a free answer.
Very nice. Who is We Love You? You? Aw.
Who's Angry Wood?
We love you too.
Oh, sir, Mr. Dr.
Who's Angry Wood?
What's up? It's an upset.
Who is Angry Wood? Oh, very good. You're not. It wasn't 33-year-old Joe. Oh wow. Surprise, surprise. Who is Uh-oh? Oh, very nice. Very good job. Your free answer is C. Let me check the board real quick. Wait. Oh my goodness. That happens less commonly now that we have EMRs, but I will still tell you that I get some really goofy stuff put in there, and they're like, hey, I figured you guys would catch it and would fix it for me. Not the right mantra to go with, but okay. All right, if nothing else, I will see you guys next time.